Sejam bem-vindos à TV SBU, na cobertura do 15º Congresso Internacional de Uro-Oncologia, onde a gente tem a oportunidade de receber diversos ícones da medicina, urologia e oncologia internacionais. Hoje temos conosco a professora Maha Hussain, que é professora de medicina e diretora de departamento do Centro de Câncer Laurie, da Northwestern University in Chicago. Welcome, Professor.
Thank you very much.
Thank you very much for your time with us. And I invited you to a little talk about PARP inhibitors.
Certainly.
PARP inhibitor is a sort of new therapy on cancer, on prostate cancer, but it brings us one intriguing question about the treatment of prostate cancer patients. That is individualized medicine, there is precision medicine in oncology and in prostate cancer care. What you can tell us about some part of history of PARP cancer or PARP inhibitors on cancer treatment,
Sure.
and the new horizons on prostate cancer treatment on individualized medicine?
Thank you. So great question about the role of PARP inhibitors in cancer in general, but especially in prostate cancer. As I showed in my presentation, the history of PARP, the pathway research, goes back to the 60s. And this has kind of evolved over time. And in reality, it's 60 years later that the PARP inhibition was evaluated specifically in prostate cancer. Prior to that, it was actually investigated in ovarian cancer, breast cancer, pancreatic cancer, and so on. So in prostate cancer, the first set of data that demonstrated the value of PARP inhibition in the context of men with metastatic castration-resistant prostate cancer who actually had the qualifying mutations with BRCA1, 2, or ATM, or part of another panel of expanded panel of HRR mutations, actually happened in 2020. And clearly, somewhat about 20% of the patients actually have the mutations. So I would definitely encourage that men are in their tumors, and now that we have ctDNA, definitely investigating that part to see if in fact they have the mutation so they would qualify for treatment. At this point, when PARP inhibitors were first tested, were actually in the second-line setting in castration-resistant disease. And in fact, when we published the PROfound trial, we also listed the number of prior therapies, and all of these men had seen multiple lines of therapy, including close to, I want to say, more than 50%, if not more, have seen multiple chemotherapies. And so now things have moved into the earlier phase, frontline castration-resistant disease, again in men who have the qualifying mutations in the context of combination with an AR inhibitor.
Good. And to think about when it's the appropriate time to take the genetic testing. Here in Brazil, we have some kind of low access because of income
Yes.
to these tests. So when face-to-face to the patient is the great time to propose these tests.
Yes. So I would say for sure when men progress to castration-resistant disease, definitely that is the time for sure to go and do the testing, definitely. As you know, a lot of these men do not progress by scans right away. When they're progressing, the PSA goes up. So generally when we see a signal that the patient's disease is moving from hormone sensitive to castration resistant disease, that would be a good time to think about testing. Having said that, I would say if you have patients with metastatic disease, and let's say they are de novo, they just presented with metastatic disease, definitely I tend to send their tissue for testing in preparation for down the road potential need for PARP inhibitor. And the reason I say that is, again, the tissue quality goes down over time. And so while you have the tissue, this would be ideal. The other part of testing, which I didn't comment on, is the germline testing. So again, if you're seeing patients who are presenting with metastatic disease, or progressed very shortly from early stage disease to metastatic disease. These are the patients that I would say definitely by guidelines criteria, it would be very important to test for germline testing. And that should be easy. It's either a buccal swab or a blood test, and hopefully that could be covered, because it also has, if they have germline mutations, it'll have implications for their family members and things like that. One thing to highlight is that obviously patients who are germline negative could still be somatic positive. So that's another time where, again, depending on the timelines and the cost, if they're positive by germline, I wouldn't bother do the somatic. But if they're germline negative, I would definitely do the somatic.
Nice. And one last question, if you mind. We are mainly urologists on Brazilian Society of Urology, and these medications seem like to be some kind of oncology site of treatment. Do you figure out in the future some possibility of PARP inhibitors on localized or locally advanced disease?
Yeah, so this is an excellent question. I would say PARP inhibitors, as I showed in my slide, there are multiple different trials in earlier stages of the disease. So I think a lot of them has to do with more aggressive potential or more locally advanced or early stage metastatic disease. It'll be interesting to see what the readouts will be. The one thing I would say also for management, I think partnering with medical oncologists, because there is toxicities. And in fact, your surgeons are operating, so you need to either have nurse practitioners or colleagues in medical oncologists that can help you with managing the toxicities.
E muito obrigado a vocês que estiveram conosco aqui em mais um momento de entrevistas muito valioso para a TV SBU. Para você que ainda não se inscreveu, se inscreva e ative o sininho para ter todas as notificações e de novos vídeos e de novos conteúdos. Muito obrigado.